Thank you for the opportunity to present my research here. My research is prevalence and factors associated with sexual dysfunction among pregnant women attending an antenatal clinic, Colombo, Sri Lanka. So I'm the main investigator, and my supervisor is Dr. Pumi Pereira, consultant venereologist and sexual health specialist. So background of this study is that the sexual dysfunctions are difficulties encountered by adults during personally satisfying and non-cohesive sexual activities, and they could last for several months and cause significant and about the pregnancy brings about numerous changes including biochemical, physical, hormonal, and affecting their day-to-day lives, and also including their sexual health. So also in Sri Lanka, the situation is that research in the field of sexual health is lacking, but as you can see, more opportunities are emerging. So my aim of this research is to reduce the gap. Objective of the research is to find the prevalence and factors associated with sexual dysfunctions among this group of pregnant women attending an antenatal clinic, and to compare the prevalence and factors in each different trimester. This is a cross-sectional descriptive study with the participation of 246 pregnant women, and all the pregnant women who are 18 years old and with the pregnancy confirmed by ultrasound were recruited to the study, and excluded were contraindicated for women with contraindications for vaginal intercourse. And study setting, as I told, it is an antenatal clinic of Castle Street Hospital for Women. It is one of the leading maternity hospital in Sri Lanka, and ethic clearance was obtained by Ethic Review Committee of Faculty of Medicine, University of Colombo. And this data collection, it is I use as the data collection tool. I use self-administered pre-tested questionnaire containing 4 parts. First part is socio-demographic data. Second part is details of previous and current pregnancy, and the third part is female sexual function index. About the female sexual function index, it has been widely used all around the world to assess women's sexual dysfunction in different groups and different populations. And fourth part was I asked few questions regarding their attitudes regarding sexual activity during pregnancy. So the female sexual function index contains 19 questions representing 6 domains of sexual function: sexual desire, arousal, lubrication, orgasm, and satisfaction. So these are some of the demographic data. Mean age was 29.5, and most of them were from Colombo district, and they were educated up to O-level levels, and most of them were, like almost all of them were married, and most of them were primiparous, and more were in the third trimester. This is now coming to some kind of analysis part. So this is sexual activity during pregnancy. So it is nice to see that 73.5% of women have had sexual activity during pregnancy, but unfortunately 16.3% of women reported not having sexual activity, and another 10% of women reported having some kind of sexual activity without penetrative sex. And of those women who reported not having sexual activity, most of them were in the third trimester. And this is the trimester distribution of mean FSD. So about the FSD, the score is higher, it means less sexual dysfunction. If the score is low, it means more sexual dysfunctions. So you can see here in the first trimester, it is 26.7. That means less sexual dysfunction in the first trimester, but coming to the third trimester, so across the pregnancy, it is the sexual dysfunction more prevalent. So you can see it is a reflection of the previous slide. So the prevalence of sexual dysfunction during pregnancy, overall prevalence was 68%, and in the first time it is 56, and it has risen to 76.8 in third trimester. So this is about the comparison of mean scores. All the mean scores shows this similar pattern. Actually, this similar pattern. Their scores reduced in the third trimester, except some the pain. You can see here the green line shows pain domain. Only the pain domain showed some improvement in the third. So associated factors, third trimester showed higher prevalence of FSD than the first trimester, and it was statistically significant. However, there was no statistical significant difference between first trimester and second trimester, or second trimester and third trimester. And scores of all the domains showed similar pattern, and having higher education and being employed were associated with lower level of sexual dysfunctions, and believing sex during pregnancy will harm the fetus, and it is highly statistically significant, and on going through normal vaginal delivery will have a negative impact on sexual life were associated with FSD, and no associations observed between total FSD score and age of the participant, district, religion, parity, having a history of normal vaginal delivery, cesarean surgery, or miscarriage. So limitation of this study is it is actually, when I was preparing my proposal, I wanted to do a comparison between pre-pregnancy sexual dysfunctions and pregnancy in the prevalence during the pregnancy, but due to the potential recall bias, and which could have significantly affected the study's validity, I changed it to find the prevalence during the pregnancy, and that was one limitation. And also, this is a cross-sectional study carried out at one antenatal clinic in a single hospital over 4-month period. So due to the functional design of this study, generalizability is limited. Another limitation is I only assessed pregnant women's factors, but I could not assess partners' possible influence. So this could have I can further extend this to another study to involve their partners as well. So conclusion of this study is the overall prevalence of sexual dysfunction among pregnant women was high and worsened as the pregnancy progressed. Misconceptions regarding sex during pregnancy also were associated with high levels of dysfunctions. And recommendation, so as we can see here, we are talking about sexual and reproductive health during reprosex. So but as 59% of women during pregnancy, if they are affected with the sexual dysfunction, it brings that question, what we have done and what we can do. So it is so I hope that it will be it will give an eye-opening message to the stakeholders to take necessary action. Acknowledgement, I would like to give the acknowledgement to all the pregnant women who participated in this study and my supervisor. And I did this for my master's degree. The director of sexual health, Masters of Sexual Health, Dr. Nisha, for the immense support, and all the consultant obstetrician and gynecology at State Hospital. These are my reference. Thank you.
Thank you, Professor, for the introduction, and good afternoon, everyone, and thank you very much for being here today. I'm very excited to share with you my research on menstrual stigma and assessment of the Sri Lankan perspective, with a focus on individuals with advanced level education or higher. So let's start by setting the stage. So let's start by setting the stage. So what is menstrual stigma? It can be defined as like a mark that brands a menstruating person's body or character as like damaged. And this can be also seen in like a patriarchal context as something that reinforces the lower social status assigned to feminine. So the main objectives of this study is to understand the dynamics of menstrual stigma in Sri Lanka through the beliefs and responses and experiences of the participants. And there are also 3 sub-research objectives. First is to understand what stigmatizing beliefs about menstruation the participants hold. The second is to understand how stigma shapes the way in which the participants experience and engage with menstruation. And the third is to understand how the participants perceive menstrual stigma and how they respond to it. So, thank you. Let's talk a bit about how the study was conducted. So, I employed a mixed methods approach. Data was collected through 100 questionnaires and 10 interviews. And the data was analyzed qualitatively using thematic analysis and quantitatively using Excel and Startup. The population of the study is Sri Lankans with education of advanced level or higher. And the sampling method was convenient sampling, and as for the sample composition, it was representative of all 9 provinces of the country, and 72% were male, 28% were female, and 88% were below the age of 40. The rest were above the age of 40. And of the sample, 98% held either a university degree or a professional qualification. The others had advanced levels. And out of the respondents, 85% answered in English and the rest in Sinhala. Just 2 things to note here. One, the findings cannot be generalized to the entire population without limitations. One is because the sample size is quite small, and also because it's not representative of all demographic features of the population. And 2, the Tamil language not being used in data collection is a limitation of this study. So that brings us to the results of the study. So before I begin, just want to note that they're arranged in 3 sections that are in line with the 3 research objectives mentioned earlier. So we'll start first research objective, which was to understand what stigmatizing beliefs the participants hold. So what we found here is that while a majority, that's 71%, believe that it's acceptable for men to buy menstrual products, there are gender differences in this view. That is, slightly more males, 75%, hold this view compared to females, 69%. So this actually indicates a slightly more open view among the males than the female. Conversely, more women, 88%, than men, 79%, believe topics such as access to menstrual products should be discussed in public. Then in another question, when asked if it's acceptable for a menstruating person to be more angry or sad or moody, what we found is that 33% of the male respondents said no, while only 13% of the female respondents said the same thing. This possibly indicates a higher level of sympathy or understanding for menstruating people among the female respondents. Then on views about celebrating menarche or the first menstruation also varied across gender and age. So those over 40, 16% of them favor menarche celebrations more compared to those under the age of 40. That's 11%. Then more males, 18%, than females, 10%, support menarche celebration. So this is kind of significant given that almost twice as many males than females support this usually traditional view of menstruation, which is essentially a female experience. So moving on to the second part of the results here, which is on how menstrual stigma shapes the way in which participants experience and engage with menstruation. So to further understand like the self-perception and the experience of a person going through menstruation, we asked about self-consciousness. So what we found was that 43% of the participants said that they feel highly self-conscious during menstruation. 50% said that they feel somewhat self-conscious. Similarly, when asked how they feel in terms of attractiveness during menstruation, 32% reported feeling unattractive. A third finding here is that almost half the women, that's 49%, said that if they need to be excused from a social situation due to something like menstrual cramps, they won't cite the actual reason and will instead give a different reason, such as a headache. There's one more finding here, that's that comfort discussing the topic of menstruation also varies across gender and age. So females reported feeling more comfortable talking about it, any other females over even a male medical professional. And even for the male respondents, the most comfortable group for them are female medical professionals. And in general, older respondents reported more comfort than younger respondents in talking about this topic. So that brings us to the third part of the findings, which is on how the participants perceive menstrual stigma and how they respond to it. So here we looked at whether participants believe menstrual stigma to be prevalent in Sri Lankan society. So what was found is that 53% overall feel it's prevalent, but here also there is a generational disparity. That is 58% under 40 believe it to be prevalent compared to only 16% above the age of 40. Similarly, there is a gender disparity also here, more females than males believing it to be prevalent. Finally, we see that 13% of respondents associated the word or the concept of menstruation with the word pure, which is interesting because traditionally in most Sri Lankan societies, menstrual blood has been seen as impure. So in a context where 53% of a group feels menstrual stigma is prevalent, 13% saying that it's also pure could be an incident of them resisting the existing menstrual stigma. So in conclusion, while most questions generated overall positive responses, there are gender and age disparities among those who don't hold typically positive or non-stigmatizing belief. And further interviews with medical professionals suggest a decrease in stigma due to internet access. However, some of the younger professionals I spoke to still see this as an important issue. So older participants perceive reduced stigma while younger ones recognize its persistence. And so this could reflect a generational or societal change. Coming on into the recommendations of the study. Interventions should enhance internet-based education, promote open discussion among youth, and support movements normalizing menstruation. And this should be done while giving consideration to age and the gender of beneficiaries, as we have seen some differences there, to effectively bridge the perception gap and improve the menstrual health discourse. Thank you very much.
Thank you very much, Thiruni. And we will move into the third presenter. Third presenter is Kavesha Kumarasinghe, and the presentation is on family planning utilization trends in Western Province 2017 to 2023. Kavesha.
Good afternoon all. I'm Kavisha Kumarasinghe from Non-Communicable Diseases Research Center, University of Sri Lanka, and I'm the research assistant there. So today I'm the presenting author for the abstract Family Planning Utilization Trends in Western Province from 2017 to 2023. So, it's our research team from Non-Communicable Diseases Research Center, University of Sri Lanka, and Department of Community Medicine, Faculty of Medical Sciences, University of Sri Lanka, and Family Health Bureau, Ministry of Health, Sri Lanka. And let's forward. So before going in detail to the study, let's see some background about our present condition. So family planning plays a major role in maternal and child health, and it helps reduce unintended pregnancies and support sustainable population growth. So among reproductive age women in Sri Lanka in 2021, 56.2% were using modern family planning method, and 6.8 have an unmet need for family planning. And in Sri Lanka, method mixed family planning methods are offered free of charge in the field level, but still there are some issues like accessibility and cultural attitudes, education and healthcare policies deeply influence the adoption of family planning methods. So in such ground, the study was planned to describe the family planning utilization trends in Western Province from 2017 to 2023. So let's move on to the methodology. So the study carried out at 5 health service areas: Colombo, Gampaha, Kalutara Regional Director of Health Services, and National Institute of Health Sciences, NIHS, Kalutara and Colombo Municipal Council. And it was carried out as a descriptive cross-sectional study, and our parameters are like percentage of eligible couples with unmet need of family planning, and percentage of eligible families using a modern family planning methods or traditional family planning method, and modern family planning methods by types. They were used to describe the trends, and the data they were secondary data compiled from monthly statement of public health midwife from 2017 to 2023 was used with the Family Health Bureau. And correlation with national data was assessed using a Spearman correlation coefficient. That's the methodology. And let's move to the results. So you can see here line graphs showing the trends in modern and traditional family planning method with the national average. And in the figure 1, you can see percentage of eligible couples using modern family planning method, and the figure 2, percentage of eligible couples using traditional family planning planning method, and the dotted line is the national average, and the other colored lines are about the RDHS, NIHS, and Colombo and Kalutara municipal councils. So you can see in percentage of eligible couples using modern family planning method, there's a we can observe upward trend in national level. So as in the Colombo municipal council, and the highest rate of using modern family planning methods you can see in the Kalutara RDHS, and the lowest can be seen in Gampaha RDHS. And the Colombo municipal council, which is in the purple color, you can see it aligns with the national average in 2022 and 2023. And if it comes to the percentage of eligible couples using traditional family planning methods, you can see the national average in the dotted line. It is static throughout the years, but in the blue color one, the NIHS one, you can see the downward trend best in the NIHS, and the yellow color one, the lowest one in Kalutara RDHS, and the highest trend in traditional family planning methods you can see in the Gampaha RDHS. So let's move forward. Here's the correlation between provincial data of family planning, provincial users modern family planning methods, and users of modern family planning methods in national level. So there was significant strong correlation between provincial and national data. So that's about the results. So if we move forward, in conclusion, we can say modern family planning methods usage in Western province increased aligned with the national trends from 2017 to 2023, while unmet need for family planning is declined, and statistically significant correlation was observed between national and provincial data on modern family planning usage. And we analyzed the modern family planning methods with types also. So there we can see there was a upward trends in implants and DMPA, and there was a downward trends in IUCD and oral contraceptives and permanent family planning methods as usual. And traditional family planning methods, as I showed you earlier, it remained static throughout the period. So finally we can recommend we should do further research to find the reasons for usage of traditional family planning methods to remain static and decline in IUCD and OCP to be carried out. So these are the references we used. So thank you.
Thank you. And our next presenter is Kumudu Sumedha, and she's making presentation about exploring disabled male veterans subject positioning and gender identity construction in sexually intimate relationships.
Good afternoon, everyone. Today I am presenting a very small section of my doctoral research. The topic, as Sir said, exploring disabled male veterans, submission and gender identity construction in sexually intimate relationship. Before moving on to the objective, I would like to explain a little bit of the reason that I have done this research. It's basically about the lived experiences. Actually, I explored lived experiences of disabled veterans, masculinity and sexuality. It's a critical phenomenological exploration, and while doing my literature survey, actually I found extensive research on disabled veterans in the Sri Lanka Army. However, despite this attention, there remains a glaring gap in research concerning these veterans' experiences relating to their sexual well-being in their post-conflict. So, I'm Kumudu Sumedha. I'm a senior lecturer in the Department of Sociology, University of Scalonia, and my supervisor is Dr. Russell Shuttleworth, and I did my PhD at King University, Australia. So the main objective today I am presenting is part for one objective in the doctoral study. The main objective is basically integrate how disabled veterans discursively negotiate their masculinity and sexual lives. So through that objective, I decided to present this particular objective, a section of that. A major objective of this research was typically integrate how disabled veterans position their masculine subjectivity in terms of their sexual and intimate relationship. The methodology, it's a qualitative methodology, and the both methodology and the conceptual framework of the larger study draws from interpretative and critical paradigms used, critical disability studies and critical phenomenology. The larger methodology actually had two phases of data collection. One is in-depth life history interviews with 12 disabled veterans, interviewing one participant 3 to 4 times, and the second phase of the research was participant observations of 7 social events. But particular to this presentation, this part actually, it's I grabbed data from these 12 interviews. So data analysis, this part of the objective was analyzed through discourse analysis, and discursive psychology is one way of doing discourse analysis. Under discursive psychology, there were 3 theories that I've used: interpretative repertoires, ideological dilemmas, and subject positioning. So subject positioning is the major way that analyzed this particular study. So the research was conducted with the approval of Deakin University Human Research Ethics Committee and was completed in 2023. So the results, participants, the 12 participants, those who are having physical impairments, express 3 distinct types of masculine subject positions in related to their sexual intimate relationships. So I analyzed these different findings under 3 groups. Actually, I clustered these 12 participants under 3 groups. So the first group, the one group of research participants primarily maintain a traditional dominance sense of their masculinity and role in their sexual encounters and relationships. So here you can see the interview excerpts for an example, since this is a very qualitative study and analysis, and I actually analyzed the way that they use language to position or to position their masculine identity and also to construct their masculinity during these interviews. So for my masculine personality, it won't affect me much because I am blind only. That doesn't make big trouble. But in the case of paralyzing or physical disabilities, it will affect much. Then the feminine side should play a big role. In our case, that is different. I play the leading role. My wife is much cultured. So here, when you see how this person who is having visual impairment, so he directly positioned himself as dominant, and he said since he is blind, that doesn't make big trouble. So that means his impairment. So he said his impairment doesn't make a big trouble to play his gender role, like to play his dominant gender role during the during his sexual relationships. So, but he said, with compared to other impairments, so they have different limitations in playing their dominant masculine role. So also here, the feminine side should play a bigger role, the supportive role of female sexual part. If we move to the second group, the second group of participants were less inclined to identify as dominant and often viewed themselves as passive and diminished in their masculinity and role in sexual encounters and relationships. So this person having using a prosthetic leg, and in his situation he has to set the artificial leg aside, and he frames the sexual act immediately in negative term. Like, so you can see here in his words, we can't act drama scenes. Javanika danda beha. So as a male in Sri Lankan society, so he thought like he has to play the major role, and he was regretting, and also the important thing is these men are comparing their sexual life experience before and after. So before they're comparing their performance, like sexual performance, before becoming disabled and after becoming disabled. So that's why he's comparing his situation and saying we can't act drama scenes, we can't jump like her. So he's comparing his situation with the female partner, and so that's the reason this person is less inclined to identify him as a dominant position. So yeah, so and also you can see the feelings of depression, shame, and so thinking and comparing his situation with the social construction of masculinity, the masculine role in sexually intimate relationships. And the third group of participants, especially those facing diminished sexual function and impairment, often prioritized emotional connection and companionship and downplayed the masculine role of being sexual initiators or aspiring to dominant masculinity. So the third group is especially they are having multiple impairments, for an example like having down waist paralyzed, and also having nerve issues, so they can't move their hands, they can't move their legs. So these two participants, they did not actually position themselves as dominant or passive. So what they expected is a romantic relationship rather than a sexual relationship. They did not express their idea related to marriage. So you can see in the given example, if I can be with someone, I don't want sex also. Just be my side and talk to me. So you can see the way this person is expanded his sexual repertoires and explaining about love, attention, care, and a partner to talk. And he said, I don't want to show the world that I am a man, but I want to feel that I am a man. So feeling like a man means that he wants a partner and to talk with him rather than performing a dominant masculine role in his sexual relationship. So these are the three groups of men that express their sexual life experiences. In the conclusion, responses on masculine identity construction were not wholly fixed, and depending on different factors and context, some men express more than one type. So here their experiences and their masculine identity construction is not wholly fixed, because it's depend on sometimes with their partner, the partners respond. For an example, one participant said we depend on his female partner's continuous support and yes, especially with the support of his female partner, so he feel he's performing his duty well. So, and also some men, they are having compensatory relationships. What I mean by compensatory relationship means some were married to a young woman who's having a big age gap, and some were married to women from poor backgrounds, and some were married to uneducated women, so they can compensate their relationship. So that also affected to their masculine construction in their sexual and intimate relationship. So so this demonstrates a fluidity reflecting the masculine identity's complexity, because when I discuss with them regarding their previous experiences, like before becoming disabled and after becoming disabled, so this comparison, it reveals the complexity and the fluidity of their masculinity. Those who wanted to become a man through their sexual act, like the dominant sexual act, but after becoming disabled, so they are ready to having kind of a sexual intimate relationships with a partner who they can talk with. And these various subject positions reflect the ways that disabled veterans negotiate and construct their masculine identities in the context of developing and maintaining their intimate and sexual relationship. The recommendations, whether it's happening or not, I have recommended several things to as an outcome of this study. So one is education on how masculinity intersects disability and sexuality, which is crucial for disabled male veterans as it helps address their own experience and challenges. Especially I recruited participants from several rehabilitation centers and also from the community. So mainly these education programs are medically having a more medical approach than a social approach. So I thought giving a better sociological aspect and plus medical aspect is better for their rehabilitation process. Additionally, staff who work with disabled veterans and their partners should receive comprehensive training to ensure they can provide informed and empathetic support. Such educational and training initiatives must be sensitive to differences in gender and sexual orientation. This holistic education framework will foster a more inclusive understanding of disability and sexuality for everyone. Moreover, insights gained from this research with disabled male veterans on their masculinity and sexuality may also inform broader discussion relevant to all disabled men in Sri Lanka, with particular to disabled male veterans. So these are the references. Thank you very much.
Thank you very much, Kumudu Sumedha. And we will move to the fifth presenter. Fifth presenter is a Komlan Christian, and his presentation will be on in-depth analysis of the drivers of unintended pregnancies among adolescent girls and young women in the Atlantic Department of Benin.
Thank you, dear professors. Good afternoon, everybody. I am Komlan. I come from Benin. Benin is a country in West Africa. Okay. In introduction, unintended pregnancies form a major public health challenge in Benin, affecting many young women, girls. Between 2015 and 2009, 39% of pregnancies were reported in unintended, with more than one-third estimate to have ended in abortion. In a country like Benin, where safe and legal abortion services and hard access, most of these abortions take place using unsafe methods. To reduce the high incidence of unsafe abortions, it is crucial to understand the underlying factors driving unintended pregnancy objective. Okay. This research aims to identify and analyze the main drivers on unintended pregnancies among women and adolescents in the Atlantic Department. Atlantic Department of Benin is on south on the country. It seeks to shed light on the socio-economic, cultural, and educational factors that contribute to this phenomenon. Methods. The data used in this article were obtained as part of a larger qualitative study on the social determinants of abortion and care pathways in Benin. The research was conducted in the Atlantic Department of Benin, chosen because of its alarming reproductive health indicators, including a high unmet need for contraception and a high uptake of safe abortion service. Results. Precarious socio-economical conditions combined with deeply inequitable gender norms form the root cause of young women's vulnerability to unintended pregnancies in Benin that manifest through different drivers. Firstly, adolescent girls and young women from disadvantaged backgrounds are often forced to support themselves or their families at a young age. This situation forces them to make difficult decisions, such as engaging in transactional sexual relationship in which they lack the power to negotiate contraceptive use to prevent getting pregnant. Secondly, inadequate access to accurate information clearly plays an important role. Our findings reveal that sexual education, both at home and at school, is insufficient and deeply influenced by harmful gender norms. Therefore, girls and boys in relationship lack information to sufficiently protect themselves. Furthermore, different levels of sexual coercion were found to play a role in the occurrence of several unintended pregnancies in our sample. On top of these factors, contraceptive use is extremely uncommon. Young women who do use contraceptive are accused of being prostitutes. Also, other obstacles to contraceptive use were found, including fears of side effects and access constraints. Traditional alternatives are sometimes preferred because they are more accessible or can be used discreetly. Conclusion. The drivers of unintended pregnancy in Benin are complex and intertwined. Limited access to sexuality education and contraceptive services, and culture and religious pressures influenced by economic and gender inequalities together contribute to a low uptake of modern contraceptives by adolescent girls and young women. This in the turn leads to a high prevalence of unintended pregnancies and unsafe abortions within this group. Understanding these drivers and how they interact is essential to developing effective prevention strategies. They are tailored to the needs of women and girls and help tackle the root causes of inequality. Recommendation. To reduce the incidence of unintended pregnancies, it is crucial to strengthen sexuality education in schools, to support parents in their communication about adolescent sexuality, and to promote youth-friendly access to modern contraceptive methods. However, without addressing the gender inequitable norms that form the root causes of young women's vulnerability to unintended pregnancies, these interventions are unlikely to have a sustainable impact. In addition, target economic intervention are needed to reduce vulnerable women's dependence on transactional social relationship. Thank you.
Thank you, Mr. Coleman. And we will move into the last presenter. I think last presenter will be online. Therefore, see.
Welcoming
Okay.
ladies and gentlemen and the audience to my presentation on menstrual hygiene practices among ordinary level girl students of schools in Kilinochchi district, Sri Lanka, a cross-sectional study. I am Dr. Bahiran, Master of Public Health student at the Department of Public Health, Faculty of Medicine, University of Kelaniya, and currently attached to Department of Radiology, Teaching Hospital, Jack. My supervisor, Dr. Dinesh Khonke from the Department of Community and Family Medicine of Faculty of Medicine, University of Jaffna, Sri Lanka. So, objective of this study is to describe the menstrual hygiene practices and analyze them. What is the relationship with the socio-demographic characteristic among the ordinary levels girls in Kilinochchi? What the methodology we have practiced here is we have designed the study design as a descriptive cross-sectional study on menstrual hygiene practice. The study period was around 4 to 5 months in Kilinochchi district. Schools and students have been from the 82 schools and 2,200 students in total. Sample size we have calculated nearly 385 students with using 0.05 margin of errors, 95% confident intervals with a p-value is 0. Sampling method, which is multi-stage cluster sampling, where we have selected 20 random schools. Data collection was the structured self-administered questionnaire because of the sensitive questions and the observation checklist by the data collector. The questionnaire reliability was really high. Crunch alba is 0.927, and the data collectors were trained development officers from the zonal education department of the Kilinochchi district with a minimal disturbance of during the data collection, avoiding disturb. Data analysis was using IBM SPSS statistic version 26.0 using descriptive statistic and high-score test for comparison. So ethical approval we have obtained from ethical review committee of the University of Kelaniya with a parental consent throughout the study. So what we have obtained the result is nearly 75.9, nearly 295 of them are the Hindus, and important thing is the family income of the district is nearly 25,000, less than 25,000. It is equal nearly 73.5% of the total population. That means 283% of students are coming from the 25,000 earning capacities. So where they have used, you see the father's educations and the mother's educations level. Mostly they are from the O level, and the advanced levels is nearly 75 in number. 175 have completed the OL. When we go further on the practices, all the students uses sanitary pad, but only 35.1%, nearly less than half, 135 students change them frequently at school. So this is very important point why that is so much low. So access to toilets, 92% having access to the covered toilet at home, nearly 355% of students having that facility. And when we come to the menarche, average age of menarche is 15.3. So mean menarche is 20.97 years. So menstrual cycle average cycle is lasting 5 days, but most cycle is shorter than 28 days altogether. So comfort discussing menstrual hygiene and its practices, only 24.4%, nearly 94%, 94 people, students have felt comfortable discussing menstrual hygiene open. So the result of the water and toilet cleanness. So inadequate water facilities and poor toilet cleanness contribute to the infrequent changing of the pad. So that is why they don't go frequent changing of the disposal of absorbs. Nearly 33% dispose used absorbent in bins, while another nearly 33% equally burn them. So access to clean water. 68% have access to clean water and sanitation, whereas 31.7% faces challenges mainly water availability and toilet. So school facilities. Nearly 39.7% of schools do not have the clean functional toilets, whereas 58.8% lack sanitary napkin display. So significant findings where we have used the high scale shows that significant association between the access to clean water and sanitation and menstrual hygiene, changing absorptions in schools and changing pads and disposal methods are significantly contribute. Finding highlight that need for better facilities and educational resources for menstrual hygiene. So from that, we come to the conclusion that influencing factors where menstrual hygiene practices are shaped by cultural, religious, and socio-economic factors. 92.2% of students have access to toilets at home, but privacy and sanitation concern person. Whereas economic limitation, financial constraint impact access to menstrual hygiene products, with the sanitary pads being the preferred. Educational support, there's a need for better education on menstrual hygiene and usage of both sanitary pads and products. School infrastructures is very important, where insufficient water supply and the inadequate disposal facilities in schools highlight the gaps in menstrual hygiene management. Urgent improvement, the study stresses that needs for improved infrastructure and educational resources to support menstrual hygiene. What we recommend from this study is clean, well-maintained toilet and proper disposal systems are critical for improving the menstrual hygiene practice, which is supported by the study conducted by Determinants and all in 2020. Whereas access to water and hygiene, reliable access to clean water, soap and hand washing facilities is essential, along with the consistent maintenance. Comprehensive education, school should introduce educational programs covering menstrual health, product use, and stigma reduction as recommended by UNICEF in 2020. We also recommend support for low-income families. Affordable menstrual products should be provided with NGOs, collaboration supporting accessibility for economically disadvantaged students. Inclusive facilities must cater to students with disabilities, ensuring all have access to appropriate resource. Curriculum integration. Menstrual hygiene education should be incorporated in the school curriculum with policies for regular inspection to ensure compliance and the continuous improvement, as recommended by FES and WISWAS group in 2020. So this is the end of the presentation of our study. Thank you for.
Thank you, Dr. Pakirtharan, and I hope you will be available for the discussion time. Now we open for the discussion, and we have 6 presenters. We have about nearly 20 minutes. I would like to take very few questions from the audience. Of course, there are 6 presenters, therefore at least we can have 2 questions for each presenter. Now we will take the first presenter, Dr. Sandun Rajapaksa, and he made the presentation about the prevalence and factors associated with sexual dysfunction. I think I will start one question from the doctor, and probably from the audience also, and my co-chair also can ask questions. And as you mentioned very clearly, in the first trimester, sexual dysfunction is significantly lower, isn't it?
Yes.
And the advanced, third trimester, it is much lower. Have you done anything about the controlling the parity in the sense that null parities and parity 1, parity 2, because, those who have gone to the higher parities, they have more experience about the situation. My question is basically, have you done anything controlling the parity matter? And also the link question is that in medically or health conditions are concerned, there is advantage of sexual functions during the pregnancy for the delivery and other items are concerned. Probably you can comment quickly. Yeah.
For the first questions, I actually took the data about the parity. Then anyway, I divided into multiparous and primiparous. But then I tried to find the association, but there was no significant association between parity or having a sexual dysfunction. It is not only between primiparous or multiparous. And I did try to find the association between the advanced parities as well. There was no association. presentation. I thought there would be, but the second I didn't really get it. The question.
I think literature says that sexual activities during the pregnancy will support the delivery and other facilities later on. Is as a conclusive evidence for that from the Sri Lankan studies or elsewhere? Have you found any literature on that?
Of course, the women and men believe that having sexual activities during pregnancy will enhance their facilitate delivery. I could not find any related data, and also there are some evidence say that some chemicals in semen will dilate the birth passage cervix. So and many believe that, but I couldn't really.
Thank you. And is there any question for anyone want to ask any question? We can ask at least one question from the Dr. Sandun. Anyone would like to ask?
Dr. Sandun, I saw that there is a high correlation with the education. So that do you have any suggestion that how we should actually concern, or whether you suggest that be included in this sexual education in the school curricula or something like that?
That is, of course, a big issue in Sri Lanka, but more than like incorporated into the school curriculum, we can take necessary action to deliver this information at public health level or Ministry of Medical Office of Health or antenatal clinic. So I have worked at Medical Office of Health. In some even midwives have no idea. They are clueless regarding sexual activity. So sometimes they give the advices not to have sex. So that is a big issue.
I think from the audience, we expect at least one question. It's unfair for the chairpersons to put questions every time. Is there any single question for our medical person? If it is not, I think since we don't have much time, we will move into the second presenter, Miss Tirani, and menstrual stigma and assessment of the Sri Lankan perspective with focus on individuals with advanced level and higher education in Sri Lanka. Any question from the audience again? Now again, I put a question to the Miss Tirani, and the question is actually in your study you have two samples. One is male sample, other one is a female sample. Usually menstrual stigma is largely related to the women. Probably men also feel something transferring from the women to men. But what is the real purpose of including a male sample there? That's a question number one. And also, what is the marital duration? At the young, if their marital duration is quite shorter, the experiences are somewhat low. And also, I don't know whether you have any sort of idea that age at menarche, some sort of problems even before marriage, menstrual issues, and whether it is continuing after the marriage in a more serious manner or not. Therefore, my basic question is that have you touched upon anything before marriage part, and also why the particular male component is included? You may say that it's a couple, therefore male has been included, but is there any particular reason?
Thank you for the question. I didn't really take into consideration like relationships with men or marriage, so that's not why I included men, but because it's stigma and belief and person. So those things, because they do apply to everyone, and because even like decisions that are taken at policy levels about reducing taxes on menstrual products or having like better sanitation facilities at schools for these reasons, there are men also coming. So I think those attitudes, we have to take in their attitudes also. So that is why I consider them. But I do wish that I had more men, because there were only 28% in the sample. And no, I did not also consider married. So like whether or not the participants were married. About 88% of the participants were below the age of 40. So they were mostly young people. But yeah, I did not take that also into consideration.
Any question from the audience? Actually, we have about, I think, nearly 40-50 people. Unfair for the chairpersons to ask the questions all the time.
I think that you have meant regular as well as irregular cyclical people, right? In your study, do you have any categorically analysis on that? And even that you said that there is a qualitative part, but I didn't see that anything that in the conclusion.
Yes, in the qualitative interviews, so I interviewed 10 people and about 4 medical professionals. So did not talk about like irregular and regular periods, but then we did talk a lot about things like menarche celebrations. So those, I did not include it in the presentation, but yes, something that came out there was like most of the women remembered their menarche very vividly, like they could recall all the details, and they also found celebrations very embarrassing and sort of recall them in a negative. And that kind of like enriching that quantitative finding about like who approves of these celebrations. Yes.
Thank you. Then
Thank you. Normally, the stigma size in the menstruation. So, do you find any literature or any some insight from the findings? Sometimes they may stigmatize themselves, but not the society or in the school or workplace. There is no stigma, but themselves stigmatize. Oh, I am menstruated, so I am so stigmatize themselves, but not the workplace. So, are there any such insight from your finding?
You mean like literature that says that participants, like the stigma comes from within but not from external sources? There was little find that like a lot of female participants also hold these stigmatizing beliefs, but in general, I think it is impacted by social attitudes and all that, right? Things you learn from your environment, from your childhood. So.
thank you. Then our third presenter was Ms. Kavesha Kumarasinghe, Family Planning Utilization Trends in Western Province, 2017 to 23. Is there any particular question you want to raise to her? Her study was basically family planning utilization in the Western Province. At least one can ask why you selected the Western Province. Now, I like to ask one simple question. Now, in Sri Lanka, of course, once you consider we have traditionally accepted these items are the family planning methods or contraceptive methods. But Sri Lanka, we know that usage of postino, emergency contraceptives are there. And also medical abortion is happening very significant level to avoid the pregnancy for the postino and to terminate the pregnancies with the medical abortion. And what was the real definition you have used for contraception here? Is only traditional and modern contraceptives basically we accepted because people tend to use some other methods outside the contraceptive level?
So we use the modern and traditional family planning method. So we just use the things we are like in the field level. We are using the method mix family planning method. So we use that things to do the study.
Never ask anything about any terminations. Only the family planning or contraceptives.
Yeah.
Right.
One few questions. I didn't go through the abstract presentation. So this period is related to the COVID-19 pandemic. Did you see any differences, kind of types, contraceptive methods, type differences during the contraceptive, the usual before the COVID pandemic and then after the COVID pandemic? Are there any some changes?
Yeah, actually, we also wanted to see some differences in the COVID period other than the next before the COVID or after the COVID. But actually, we didn't see any differences between the COVID period. So it's the general thing in the modern or traditional family planning method. So we want to see some difference, but we didn't observe anything in the COVID period.
Do you think that there is no difference because of the high prevalence of contraceptive methods in the Western province? So any analysis other province?
Yeah, I think we should do other analysis with the other provinces also. But we just do the research in the Western province. So yeah, we recommend to do the research in the other areas and with the national level data also.
Yeah, in fact, it has been found with many studies that higher the education level, higher the use of traditional methods. Therefore, definitely Western province people tend to use traditional methods more than the other provinces because the education levels are much higher in the Western province. Our presenter is Mr. Coleman Tian, and his presentation was in-depth analysis of the diverse drivers of unintended pregnancies among adolescent girls and young women in Atlantic Department of Benin. Sorry, 1 minute here. The Kumudu Sumeda is there. The Kumudu Sumeda, you have to, exploring disabled male veterans subject to positioning and gender identity construction in sexually intimate relationship. Male veteran and their gender identity, intimate relationship. Any questions?
So the presenter mentioned about compensating relationships to bridge the gap between their physical disability. It's a compromise they make. Is it seen only in the severe disability, or is it seen in the other disabilities, normal disabilities as well?
Actually, it's seen within many impairments. Like it's not only severe impairments. Even for an example, one participant who is visually impaired. So we can compare to a participant who has multiple impairments. But even that person who has having visual impairments also gone through a compensatory relationship. So it's common. Thank you.
Any other question for the Dr. Kumudu Sumedha? Any other question?
It is not actually question, but actually I really enjoyed your presentation.
Thank you
Comment.
very much.
Thank
sir.
you.
Thank you, Professor.
Can we move into the other presenter that because we are running short of time? From the Benin in-depth analysis of the drivers of unintended pregnancies among adolescent girls. Mr. Coleman, he has made a presentation about why the young girls becoming pregnant and what are the reasons behind. And in fact, I have found, I can remember reading African literature that sugar daddy kind of concept that, young girls and, even we learned about that kind of, literature very much from the African continent. And you mentioned here that these girls are forced to support themselves of their families and also transsectional sexual relationships, not for the cash. What kind of items, transsectional mean not the cash, but what kind of items these girls usually get, clothes or any food or what kind of?
Thank you, Professor. I want to respond you in English, but my English is extraordinarily good. I beg your pardon to help me with my colleague Roger. I want to explain in French. C'est vrai ce que vous avez dit, que les filles et les femmes qui sont victimes de grossesses précoces ou de grossesses non désirées ne prennent pas que de l'argent, mais il y a certains avantages que les auteurs de ces grossesses-là leur montrent. On a constaté que c'est beaucoup plus les ouvriers et qui aident les élèves, surtout à l'école, mais les femmes aussi qui n'ont pas de moyens, c'est beaucoup plus les ouvriers qui enceintent ces filles-là et ces femmes-là. Et donc, les grossesses non désirées sont dues, dans un premier temps, aux moyens financiers dont les femmes ne disposent pas, mais dans un deuxième temps, à des contributions que ces hommes apportent à ces filles ou à ces femmes que ça soit sur le plan matériel, sur le plan, donc je l'ai dit, financier, mais également en termes d'apport psychologique quand elles sont dans des difficultés. Voilà ce que je peux dire.
Thank you, Professor. I will translate for us. What he says is the transactional checks for women is that I will buy for you a clothes or I can give you foods for women who don't have food for her and her baby or her girl. And I can pay for you the school fees. So it's a lot of things that men can give to women and girl to have a sex with them.
And also probably this particular behavior may leads to terminations or abortions, and there may be a lot of maternal complications and even maternal deaths also happening very frequently. I think so.
Yeah.
Any questions from the audience? There's one person raising hand, luckily from the audience this time.
Just want to know because I was in that area because with the ICRC and because there is a huge influence from Burkina Faso, Togo and Niger and related to conflict. Actually, internal communal violence are there in Benin, and because I have seen the research conclusion, it says only talking about the socio-economic factors. How about conflict-related factors? Do you have any evidence on it?
Thank you.
Merci. En réalité, cette étude a été menée dans un des départements du Sud et au Sud, il n'y a pas de conflit actuellement. Il n'y a pas d'intervention des djihadistes au Sud. Les interventions, c'est beaucoup plus au Nord, dans des zones frontalières avec le Niger, avec le Togo et avec le Burkina Faso et une partie également avec le Nigeria. Mais pour répondre à sa question, pour voir est-ce que les déplacés qui quittent leur village pour d'autres villages étant donné qu'il y a des conflits dans ces zones, oui, on enregistre également des cas qui sont liés au viol, parce que les djihadistes prennent de force les filles et les femmes, et il peut en découler des grossesses non désirées. C'est vrai que nous, actuellement au Bénin, on ne connaît pas encore cette situation de façon trop dramatique, mais au niveau de l'association béninoise pour la promotion de la famille, qui est une association membre de l'IPPF, nous sommes en train de prendre des dispositions pour intervenir, ou nous intervenons dans ces zones en stratégie avancée pour prendre en charge la santé sexuelle et reproductive de ces femmes et filles qui sont des déplacés des zones où il y a les conflits.
Okay, thank you. This study was made in the south of the Benin, but the situation that you mentioned is in the northern on Benin. But us in IPPF, who is a associate member of IPPF, we work in this area to face the situation because we don't know how it can be in the south. So we work and prevent this situation, and we work with mobile clinics to give to population more of services who can help her to have services like a clinic service and psychology services.
Thank you, Mr. Colin, and the translator also. And then our final presenter is available online, Pagirthan, and he mentioned his studies about menstrual hygiene practices among ordinary level girl students in Kilnochi, and he studied about the menstrual hygiene practices. And I want to ask very simple question from you, that as far as I remember, northern province districts like Kilinochi, there is a significantly high proportion of female-headed households, and there are sizable number of male-headed households also. Very clearly that female-headed households income levels are significantly lower compared to the male-headed household. Therefore, have you seen any difference between these two? And also you said about 25,000 average income, and how it is differ from these two groups. Thank you.
Yeah. Compared to the male-headed, it is significantly mostly in Kilinochi district, especially after the war, the conflict. Mostly they have lost their husband or father. So mostly they are the breadwinner. So mostly their income is very much low, and especially if there's any male-headed, mostly they are affected by the war, so they don't have the proper income to compete. But anyhow, most of the families are from the female breadwinners. But there's no much significant between these two groups compared to other districts, especially in Kilinochi. Both male and females are slightly marginally differences, but not that much, because their working opportunities and are very much low for them. So their earning capacity is also very much low. That's also reflected in our studies, and which going to be reflect in the near future reproductive health, especially if you take the global wise, it is 1 in every 6 people having a subfertility. But recent studies conducted by Faculty of Medicine in Jaffna by Ram and all, they have proved in Jaffna district every one of 5 people are having a subfertility. So if you don't properly address these hygienic practices, future it's going to be the drastic drawback, and especially going to affect the subfertility issues, majorly going to affect it, especially in this part of the region of Sri Lanka.
Is there any question for? You can hear there are.
I actually have 2 questions. One question is, in your study, you said that almost all participants use a disposable sanitary napkin. But did you estimate whether any of the participants also intermittently use cloth? Because a lot of young girls, due to economic issues, use cloth at home, but will only use a pad when they go to school. And the second question is whether you investigated their knowledge, or whether they know about other menstrual hygiene products like a tampon or a menstrual cup.
That is an interesting question, actually. Most of the time that even the data collectors from the zonal education department were female, but students are very reluctant because of the social stigmatization. They were telling only the pads, and they are not aware about the latest these tampons and all that menstrual cup, and we have encouraged, but it's very much less, mostly pads, or either they were telling they don't want to reveal the truth because of the economic, they might use the clothes, but in the research we couldn't prove it because the data sets was like that. They were telling that they were comfortably using the pads even though they are economically very much low. So that is actually from our part of the study. Thank you.
One question from methodology side. You mentioned it. Development officers has been collected the data. Are they from health ministry or the education ministry? Government officers. Second part, was it a structured questionnaire or whether they are open-ended was there? You mentioned it already. The answer. A lot of them were female. Or all female interviewers has been collected the data, or mix male and female, because it's for a learning purpose. What the best one? Thanks.
Actually, we train the zonal education development officers. They were previously had the experience for such similar studies. So all of them were degree holders, but appointed as development officers. So their data collecting capacity is good, and they are actually appointed as a psychological counselors in the district of Clinochi. So they were capable to handle all these issues after training given by us, and there's no male staff used for because the sensitive issues and it is not the open structured questionnaire we have used. And yes,
to you,
thank you.
You have 92% of the students have access to the covered toilets at home, but still you say there are issues remain with privacy, sanitation, even at home. I can understand about the schools where they will not have enough facilities. But what about the home? Have you gone into the in-depth analysis?
Yeah, actually the data were collecting from the parents and the students participants. We didn't actually inquire about the actually whether it's covered or not. Actually we didn't, but we believe that they were telling the truth from the parents side, confirming. And we need to do the future studies in a transparent manner to exclude those kind of information. That is really important things, as you said. True.
Yeah. You said that the research setup is a school. So did you disseminate your results to the school authority, and what is their response to?
Still, we have given the zonal education department. They are happy to. Actually, they are very much happy. We are conducting this research through the Faculty of Medicine, Kalani and Jaffna, because they were giving full support. So a pilot study we have done in Jaffna, in the SRHR. Then we have moved to the actual study center in Clinochi district. All of them were happy, but even though implementing these things, somewhat economical financial problems are there, but hopefully they will improve in the near future. We should improve altogether to have the good result in the future, because as I said, that the reproductive health of the children in the future going to be definitely it will affect the whole country. So definitely they are happy to incorporate the education and restructure all these recommended stuff through this study. Thank you.
Apologies, I think we are bombarding a lot of questions from you because I got the opportunity to listen to only you present. That's why I'm asking question. Okay, so it's a very interesting research, and I just want to clarify in the methodology you have mentioned within the Clinochi district there are around 82 schools, and your main target is girls. So have you considered out of 82 you have randomly selected 20 schools, whether there are any mixed schools, boys and girls mixed schools, or you just consider only the girls schools?
No, we use the mixed school. most of them are mixed school, and few of them are national schools. Where national schools also mixed schools. So there is very few schools are only the girls schools. So it is very difficult to isolate the girls schools like in Jaffna or in Western countries, not like Methodist or Visaga, but here it's mostly mixed one. So we have to go for the mixed.
Okay, thank you for that explanation. One more question, like among these mixed schools, have you considered the factor if there are a male or a boy in the school, whether that be a kind of a barrier for them to practice their hygienic practices when it's come to menstruation cycle and their hygiene?
Yeah, actually, it is interesting that we thought to include the male counterpart also, how they feel, how they become comfortable with the female students. But our Kalaniya University, in my supervisor, they were said, okay, only go with the female students, no need to go because it's a sensitive, because they take long time. So because based on the time factor, we were only considering the female student. But actually, as you said, it is better to include the male students also. So it will be a collaborative and a synthesized study, how they feel and comfortable with the opposite sex. Thank you.
Thank you very much. Then the last item is to hand over the certificates, and thank you very much, Doctor. Your certificate will be handed over to you later on. We can call the names now. Yeah.
Thank you, Professor Indrulaldi. We are inviting the presenters. The first one is Sandun Rajapaksha. Inviting the second presentee, Thirani Vijayavikrama. Third presenter, Kavisha Kumarasinghe. Thank you, Professor. Now inviting Professor Karuna Tilaka present the certificates to the others. Next up is Kumudu Sumeda, inviting Komlan Christian to receive your certificate. So Mr. Pakirathan is not here, so we are sending him a soft copy. Thank you. Thank you, Doctor.
No more questions. You can go and have your tea now.